Hello, clinical problem solvers. Welcome to another Tuesday VMR. Today we have a very special guest, Dr. Ian Mines. He is going to be our case presenter of today. He is chief resident this year at the UTSA, University of Texas in San Antonio. Hello, Dr. Ian. Would you like to introduce yourself, tell us about more, and what do you like to do in your free time?
Yeah. Thank you for having me on. It's a very special pleasure. Yeah, just graduating, kind of right in the transition between my last year of internal medicine and starting my chief year here at UTSA. Free time's kind of all over the place. I like to try to go to the gym pretty regularly, but I also like to cook. And I also like to play a lot of video games. So it's a big split between three different things and then trying to keep up with medicine. So yeah.
That's nice. What kind of video games do you like playing?
A little bit all over the place. It's something called RTS, which is like a real-time strategy game. It's probably the thing I play the most, and then some RPGs too.
That's nice. I don't go out of Animal Crossing. So that's it.
That's a good one though.
Very calming. And a special shout out to Dr. Asti Rezai. He helped preparing the case. Dr. Asti, would you like to say hello?
Hello, yes, my cat's in the way again as usual. But good to see everyone. Excited to have Ian here to discuss, and looking forward to hearing Ravi and Yaz go through it. So I think we can get started.
Of course.
All right. So I guess just sort of a one-liner about that patient. It was a 55-year-old male who presented to the ED complaining of left-sided abdominal pain. It started about 3 weeks prior to his arrival when he was actually on vacation with his wife in Mexico City. For most of the vacation, he stayed in the city, didn't really go outside, didn't drink any sort of abnormal water that he's aware of, got everything from a bottle, didn't eat at any sort of places off the beaten path per se in Mexico City. But then started to notice after about 3 days after return, he started feeling worse, increasing fatigue, left side abdominal pain, and then some lower left chest pain and left lower rib pain he described. And following that, about a week after he got back, he went to an outside hospital for essentially the same complaint at that time. And they treated him for pneumonia based on imaging, started him on amoxicillin and high-dose ibuprofen without really any improvement. And then he came to us about 2 weeks later. When I saw him and sort of talked with him, he noticed his eyes started to get a little more yellow than they had been before. He was also complaining of night sweats that were occurring more frequently, pretty much daily now, and had been sort of every other day or every 3 days prior to that. And then he says a 20-pound weight loss essentially over the last month, but he also says he changed his diet, so he's not real sure sort of what the cause of that was. He denied any fevers, any chills, any nausea, any vomiting, or any changes like bowel or bladder habits.
Okay, should we tackle this? Aliko, Dr. Ravi, do you want to start?
I think, yeah, this is quite a bit of information here, but why don't you start it off? Some really interesting features of this case.
Yeah, very interesting. Left-sided abdominal pain. Well, first of all, abdominal pain, it's difficult to determine exactly where the issue is, but when we're thinking left-sided, I like to think maybe if it's upper abdomen, something in stomach, something in pancreas, something like a spleen issues. Now, this is 3 weeks, so something I would definitely ask is if it's like intermittent or constant. This is looking like it's intermittent, and thinking about a travel exposure, a travel past history, I would definitely be, okay, would this be something infectious? Would this be something insidious? Now, connecting the dots, framing this patient with abdominal pain for 3 weeks, and then talking about night sweats and jaundice, I'm thinking something insidious around the area of spleen, liver, pancreas, something all in that area. And then he had 20-pound weight loss since 1 month before. So I'm thinking this is an inflammatory process, not necessarily infectious. and insidious. So that would be my first thought. And since he's in the ED, the first thing also I would look at the physical exam, if there is rigidity, if there is percussion tenderness, if there is any kind of the Murphy sign, and other signs, of course, because we're trying to locate ourselves that a patient is here, a lot of issues. And yeah, definitely that would be my first thought, like infectious versus something more insidious like malignancy due to his night sweats and weight loss. What do you think, Dr. Ravi?
Oh, Yasmin, you made some very compelling arguments there for what we should possibly invest our time in trying to solve this case here. But what really, I guess, salient features of this case, this travel history is interesting, right? What if this patient went down and acquired, we tend to have this fever in a returning traveler, and part and parcel of that is certain parasites that you could acquire down in Mexico. And with jaundice and abdominal pain and this travel history, then you have to start thinking of certain infections, maybe something that could cause hematological infections and also maybe hepatobiliary infection / inflammation. But even before jumping to a spot diagnosis, I kind of would like to, when I think about jaundice, I will always recall our friend Madalena's approach to it. She had a wonderful approach to it. So what exactly is jaundice? If you follow the journey of the hematological system and the breakdown of RBCs, you will have then certain chemicals or remnants of the RBC, which namely will be iron and protoporphyrin. And protoporphyrin will break down into biliverdin, which then will become bilirubin, and bilirubin initially the indirect. So this will be a sort of an early introduction into possibly the labs. The labs will be very helpful in this case. So the indirect or non-conjugated bilirubin isn't water soluble. Actually, it'll bind to the albumin and float around. So in this case, you won't see it in the urine in that case because it's not water soluble. So is this jaundice? Is this prehepatic? Is it unconjugated from RBCs and hemolysis, or is it a problem with the liver not being able to then conjugate it and then excrete it into the system, the digestive system? So this could also mean there's something with conjugation within the hepatic parenchyma, where you undergo glucuronidation and so on, all the wonderful stuff we learned in biochemistry, sort of reaching back years for me. But then excretion into the gallbladder and into the through the cystic duct and into the intestine. Could there be an issue there as well? So you wonder, RBC, hepatobiliary, but then you also have to wonder about certain inherited non-hemolytic hyperbilirubinemic states. So these sort of states I've never seen before, but the most common one is Gilbert syndrome that we do know about. Then there are these other ones where you have Dubin, Johnson, Roeder, and Cridgeler, Nahar, and so on. So you kind of wonder, but at 55 years of age, I think Ian would have mentioned maybe this patient's had episodes of jaundice before, so this is not the first presentation. But anyway, just cutting to the chase, the journey of jaundice, you kind of have to wonder, is this the inflection point at which you can kind of make a early diagnosis or even invest your money in ordering diagnostic tests, which could namely be imaging, and that can be costly. So you have to implement cost-effective medicine, high-value care, and so on. So I just wonder at this stage. But you take this abdominal pain with jaundice and you put it through the filter of fever and inflammation and so on, then you have to start wondering again, infections then causing this sort of presentation. But at this point, I'm not really gonna heavily say something, but or give you a early diagnosis. But at some point, we'll cross a threshold at which we can start talking about something, which could be infection / inflammation / anatomical abdominal conditions. And then also, I do want to know with abdominal pain always, it could be of any etiology, but is this patient stable? Is this an abdominal pain? I think VIPOE was mentioned early, but is this a patient that is in jeopardy? So is the blood pressure stable? Is the patient having an emergency like an acute abdomen, anything like that? Before I even start doing the diagnostic process, maybe stabilization is imperative at this moment. Anything else, Yasmin, before we swing it back to Ian?
I think you've made amazing points about jaundice. I'm definitely waiting for the bilirubin if we have unconjugated or conjugated bilirubin, LFTs, and also thinking about, since we have a patient in the ED, seeing if this is a stable patient versus not unstable patient. I think that would be in real life scenario my priority. But yeah, why don't we hear more about this case?
All right, let me add a little bit more. Hopefully it'll answer some questions. So from a past medical history, he's got hypertension, BPH, PTSD, and chronic low back pain. Past surgical history, he's had a cholecystectomy almost 30 years ago, and then had an XLAP back in the 1980s when he was in his 20s after he had a splenic laceration while he was doing a martial arts tournament. Otherwise, family history is unremarkable, no early history of cardiovascular disease. He lives with his wife at home, is monogamous, works in an office, doesn't smoke, doesn't drink, or use any substances. The only meds he takes at home regularly is amlodipine, HCTZ, valsartan, ibuprofen, and then tamsulosin. And then from an initial exam standpoint, overall relatively stable. Blood pressure was 130s over 80s, heart rate was 76, respiratory rate of 18, statin all room air, and no acute distress as general appearance. He did have some mild scleral icterus. Heart had a regular rate rhythm, no murmurs, gallops, or rubs. Lungs were clear to auscultation. Didn't have any pain, just like breathing normally. But if you asked him to have deep inspiration, he complained of that left-sided pain, particularly like left upper quadrant pain in his abdomen, but wasn't reproducible to palpation. Then abdominal exam, it was soft, mostly non-tender except for the left upper quadrant. And he would kind of call it mild, was how much he would describe it, but you could feel the tip of the spleen in his left upper quadrant. He had no edema in his extremities and had no focal neuro deficits.
So I think that after this physical examination, first of all, past medical history, I can see that he only has this splenic laceration, but I think that would be just noise if I was looking at this patient at this point. I'm also seeing that in his drugs, there is nothing that could cause a drug liver injury, like for example, some causes of jaundice. A drug that can cause jaundice is rifampin, ribavirin, probenecid, those kinds of drugs, and this patient doesn't have any of those. Now I see that he doesn't have any risk factors or social history that could tell me that there is a possibility of alcohol-related liver injury, and he has hypertension and PTSD. So right now, his past medical history and social history is so far not like my priority. Now, going into the physical examination, looking at his jaundice, he has mild scleral icterus, and I see that there are no other liver stigmata of like any chronic process in the liver. So again, as Dr. Ravi mentioned, could this be pre-hepatic, intrahepatic, or post-hepatic jaundice? And that will be something that we can determine with the bilirubin if it's unconjugated or conjugated. I'm thinking that in this case, trying to frame it again with the physical examination, the next thing that I would do would be a viral panel to also determine if this could be due to hepatocellular injury. But again, knowing that this is accompanied with night sweats, weight loss, and other of these symptoms, I'm looking into something that maybe could be non-infectious per se, but what about an infiltrative disease or a malignancy? So those will be like my next steps in this for this patient. What do you think, Dr. Ravi?
Again, some very interesting points. I agree. I'm right there with you as well. Just one key feature that I skipped over, but I appreciate Austin putting stuff in the chat, so I could sort of focus on it a bit more closely. But this a week ago was presented to a neighboring hospital, diagnosed with pneumonia, discharged with PO amoxicillin. So the amoxicillin, we were looking at medications, and we always want to then screen through the medications to make sure they don't have any bearing on a presentation. But the amoxicillin can actually cause liver injury, and it will be evident through the liver test to see if there is a disturbance in AST/ALT. And ALP would be normal in a drug-induced liver injury, though. But again, the landscape of hepatobiliary disease, if ALP is abnormal, then we have to look for an obstructive cause, whereas hepatocellular drug-induced, we will have to purely see an AST/ALT elevation. The exam, what does the exam do? Well, this patient appears stable for the moment, so there's not really extreme deviation in temperature. The blood pressure is stable, heart rate, patient's not tachycardic, oxygenation is good, and respiratory rate, patient's not tachypnic and in danger of eventual respiratory compromise. And then the key features here, there's pain with rapid inhalation and with this palpable spleen. So a spleen can be painful, and then taking a deep breath if there's spleen or splenic inflammation, enlargement, that could actually cut off a deep inspiratory effort. Just like you have on the other side, Murphy's sign can be very painful as well. So I'm just wondering, with this spleen now, you have to start thinking about things that could start disturbing the spleen, such as infiltration. What else can cause splenomegaly? This is a palpable spleen, which you on normal exam, you shouldn't be able to feel the tip. So then you have to wonder again, overlap this with possible hematological infection. I think malaria was mentioned, babesiosis. Babesiosis typically, though, what was called Nantucket disease was founded in the upper northeast region of the United States. And with that, you could call it like American malaria, but with that, typically you don't get hepatosplenomegaly. So again, you then have to wonder about malaria in this case as well. But this is kind of early. I'm really interested in the labs. This is a early hypothesis, but I don't think we've crossed a threshold to really make a diagnosis at this point. We sort of, what I'm kind of doing is conjecturing, but I think we do need more more information. Something else that I was wondering was leptospirosis also, which will be, I guess we could glean that from the labs as well, if you have the typical salient features of lepto with disturbance in the CBC as well as the chemistry. Back to you. Anything else, Yasmin, before we get the
Yeah,
labs?
no, definitely. I think that after seeing that the spleen can be, after you made a question of what can be causing the spleen to be enlarged, the splenomegaly, something that came to mind would be hemolytic anemias, and that would be causing this jaundice. Of course, there are infections that also can affect the spleen. And yeah, definitely those kinds of things are coming to mind, as well as now we can also see the CBCs, if there are any kind of cytopenias, or if there is any other clue that this could be an hematologic malignancy. But yeah, I think those are the things that I would add.
Yeah, one more point. Yeah, with the sclerolicterus, we can anticipate a bilirubin in the 2-point range and over. For skin, although I've seen 4 to 8 maybe, but 4 is usually what the range I use. So 4 to 8, you could take the average 6 maybe if the skin, but for sclerolicterus maybe around 2. And right now we don't have any catalyst to get us to the problem, but it would be helpful to make a problem representation at this point, upon which we can then add the pertinent lab data. Would you have a What do you think, Yasmin? Do you have enough to make a early problem representation?
Yeah, this 55-year-old man with left-sided abdominal pain and past medical history, notable for hypertension, cholecystectomy, and splenic laceration, and a recent travel to Mexico, accompanied by fatigue, abdominal pain, jaundice, and night sweats, and weight loss. This type of framing, after you also mentioned leptospirosis, something that I think that deserves a shout out. Laura, one of our members, taught us about whale disease or leptospirosis, hemorrhagic leptospirosis. So we have jaundice. Now we have to be very careful to see how his kidneys are working and his CDC. So I think that after that framing, that is another point in my DDX. What do you think, Dr. Ravi?
Oh, absolutely. I didn't really go, for the matter of time, we didn't really go through the causes of splenomegaly, but we did sort of dwell a bit on infection. There's infiltrative disorders. There's actually liver-associated disorders like liver cirrhosis. So hematological conditions, like you mentioned, infiltration of leukemias, lymphomas into the liver. And it also can be a source for extramedullary hematopoiesis. So we'll maybe cover those actually with more information. We'll see at this point. I can't really say what is primarily driving the splenomegaly, but it is interesting, actually. It is something that we can grab onto, and maybe it will help us to get to the diagnosis. Back to you, Ian.
All right. Yeah, there were, as you guys talked about, relatively broad diagnosis, so a lot of labs. So we'll start with the few, and then I'll have some imaging. I can try and share my screen might be the most easy way to explain it. So the initial labs, he had a white blood cell count for 11.4 with a neutrophilic predominance, with a slight monocytosis. It was about like 1,000-ish. His hemoglobin was 11.3. His MCV on that was 69.5, and his platelets were 582. His sodium was 140, potassium was 4.5, chloride 97, bicarb 25, BUN 11, creatinine 1.2, glucose 100, and then calcium of 9. AST and AL2 were mildly elevated at 78 and 88 respectively. T-Billy was 3.2. Protein was 7.1, albumin 3.9, alk phos was 279. His initial CRP was 20. The normal in that lab was less than 10, and then his ESR was 58, which was elevated as well. And then let me see if I'm able to share my screen for the CT abdomen pelvis. You guys able to see that? Here, I'll blow it all the way up.
Yeah, we can see it.
So this was the initial CTAP that he came in. We didn't have any others on file to compare previously. And if you kind of went through the spleen, it would all sort of generally look in that same appearance. And then it also happened to catch the heads of his femurs as well, which were notable for that. And then the read on those was essentially everything from the liver, biliary tree all appeared normal. He had some splenomegaly, which you felt on exam. Let me pull back and let you guys share again.
Yeah, are you able to show the
you want me to pull the image back up?
Yes,
yeah, I can
please.
pull it back up.
Yeah.
Yeah. Do you want the MSK or the?
Yeah, we'll do both actually. The
Okay.
Start with the abdominal CT. It is just fascinating that we get an insight into your patient and see what is going on.
But yeah, the read was that the spleen was enlarged. There was some trace perisplenic fluid. They said the femurs were concerning for avascular necrosis of the femoral heads bilaterally. And they noted some, I guess on the CTAP, they didn't notice that. So that was about it that was prominent on there.
Right. So absolutely what you mentioned, the spleen, there's this heterogeneity that we see in the density of the spleen here. So it's rather large compared to the liver. And then you do see the difference in the density. So this very well does signal maybe infiltration. Maybe these dark areas could be infiltration. I'm not sure if it's the lighter areas or the dark areas. Yeah, usually spleen will contrast with the liver. So the dark areas I kind of will infer will be what's in the liver. The pancreas does seem enlarged to me as well. And then we don't see anything else, the kidneys or anything. We see maybe partially the stomach. But the liver seems fine. Liver, I don't see any issues there. So we were talking about hepatobiliary issues at this cut here. I really can't see anything. But the spleen is definitely remarkable. It's really enlarged. And then I'm not sure what's going on with the femurs that you had shown there. So we'll have
There's
to go ahead, sorry.
Oh yeah, so they were commenting on, I don't know if you can see my mouse, but just the heads. There's a little bit of what almost looks like degeneration of the heads bilaterally. And the radiologist, he actually happened to have CTs at both hospitals, the one we admitted him to and the outside hospital before. And they both commented that they felt like it looked like avascular necrosis of his femurs in both reads, which was interesting.
So both femoral heads have avascular necrosis. So definitely something we have to integrate into our reasoning. So, all right, we'll go back to the labs. I really appreciate Ian bringing the images. These are really helpful in trying to understand what's going on with the patient.
Of course, of course.
All right, Yasmin, what you we can take the CBC, I'll take the chemistry, and then we'll do the imaging, integrate the imaging with whatever we come up with.
So I was expecting, not gonna lie, anemia, renal issues, but now reframing with this high white blood cells, this is more on the area of infections. We have a high T bilirubin. I would like to know if it's like direct or indirect, if there's a differential, but the alphas is high, telling us that there is something going in the bone, or there is something causing high CBC turnover. RBC turnover. And this after listening that there is a vascular necrosis in both femurs, I'm thinking there is something going in these bones and there is something inflammatory. So trying to link everything, something affecting the spleen, causing jaundice, causing like organomegaly and bone, like bilateral vascular necrosis, I would definitely agree with what already has said in the chat. The first thing that came to mind was Gaucher disease, which is a storage disease, although I would have expected this to appear on a younger patient or having any past medical history of any other issues before, because we know that in this type of diseases, we have a patient with growth delays, bone abnormalities, constant anemia, like anemia and issues. This patient does have 11.3 of hemoglobin, so it's quite low, a little bit low. So I'm thinking that could be a possibility, because another thing that I was trying to, where my Venn diagram converges and think what can cause splenomegaly and avascular necrosis can be how to say any hemolytic anemia or something like that. But again, we don't have any like low hemoglobin or reticulocyte count or anything else. So I am thinking if this could be something along the lines of a storage disease, or something like primary on the spleen. What do you think, Dr. Ravi?
Oh, well, you pretty much combined both CBC and chemistry, so I really don't have much to add. And I think I actually do agree with everything you mentioned, and integrating the radiological findings. You did a superb job on thinking of what could be causing both of these conditions. So yeah, you're right. You just mentioned something really interesting in a 55-year-old patient. Why would a patient have avascular necrosis of the femoral heads, which is very odd. So just kind of moving laterally from this case and just thinking about avascular necrosis, I kind of think of it that there's some impairment in the blood supply to the bone, and that hypoxemia that's being caused at the bone causes apoptosis of the osteocytes, and then that causes resorption then, and hence you get that image that we saw there. So you have to start thinking about what exactly is causing this death of bone, especially on both sides. So it's something significant. I don't have a very good script for this, something I would have to look at, because it's not every day I see on imaging, hey, I have vascular necrosis. But this is the beauty of cases on VMR, in that you get to learn something every day. Of course, there's the usual that we see. I see a large patient population with sickle cell disease, so it's not uncommon. Again, at 55 years of age, it's very unusual. But then rolling it back and moving back to the lab data as we moved away to consider avascular necrosis, the labs, definitely we were hypothesizing a hyperbilirubinemia above 2. The alk phos, you did a great job. You're like straight to the point that this is from the bone. It's unlikely from the liver. I doubt there's something like obstruction, any sort of obstruction in the biliary canaliculi that's causing this elevated ALP. So you always have to wonder, ALP could come from placenta, it could come from bone. In this case, bone could be the cause of this as well. CRP is elevated ESR, as Ian mentioned. So there is inflammation, as also indicated by the white cell count with the neutrophilic predominance. Is this inflammation? Is this infection? I'm not sure. So we have to sort of juggle both of these causes and then maybe purge this case through the filter of inflammation, infection, see what comes about. There are a couple of, somebody had mentioned, Hansa mentioned corticosteroids, and Shreyas actually, Gaucher's disease. I see Gaucher's disease very prominent in the chat. And is that something to consider? At 55 years of age, it's kind of unusual, but they could always be, you always have the sort of prototypical manifestations of disease, then you have the atypical manifestations of disease. This could be the atypical later age manifestation of this disease as well. So something we have to consider. But anything else comes to mind, Yasmin, while I kind of...
So far, this would be it, because I'm still very puzzled about the vascular necrosis. I think I'm trying not to anchor, but that's something that bilaterally, like you would expect that in only one side, but this is bilateral. And it is coupled with inflammation. The CRP and ESR are not that high, but for conditions that can make a patient more propense to osteonecrosis can also be rheumatoid conditions such as lupus and rheumatoid arthritis. But this patient has nothing else, it's just a spleen and bone. And I say just a spleen, but I'm trying to also converge my Venn diagram of splenomegaly and bone issues. So, yeah.
When we were talking about splenomegaly, if we now bring splenomegaly back into the picture, avascular necrosis. So those two images are key here, I think, what Ian had showed us, right? So these two images will hopefully be the pivotal point upon which we can build a differential. And we talked about infiltrative diseases, and this patient is at risk for leukemias, certainly. And you have to start thinking about what kind of leukemias in this age range could affect the bone, that could also affect the spleen. And I usually consider age epidemiologically, ALL in the younger age, and then CLL in the other extreme of age, right? What fits in between epidemiologically, AML, CML, and more likely CML. We don't have a large white count and this patient's not sick. So with an acute leukemia, this patient would definitely be much sicker. Could this be a signal for CML? Something I would add to the list of conditions that we've been discussing. But at this point, yeah, I think let's move forward. I think Ian has, how many more aliquots before the final DX?
I think basically we can probably do two more, yeah.
Okay, so we have, I think from the crowd, people have asked for smear, LDH, haptoglobin, and let's see, and some testing maybe. HIV, definitely everybody gets an HIV because it is one of the great mimickers.
I do have a question, Dr. Ravi.
Go ahead, yes.
I was just reading, going back to the labs because I'm still having trouble trying to converge everything. We have hemoglobin of 11 in a male patient, and we have an MCV of 69, so that would be low. Could we consider this like anemia of chronic disease? This is an inflammatory picture, like with these symptoms and 20-pound weight loss. Can we consider that to like an anemia of chronic disease, and maybe this could point us to again something malignant?
Yeah, actually, great point. And something's commonly I always discuss with my students, because iron deficiency anemia is always asked on shelf exams, step 2, step 3, and so on the internal medicine board exam. Also, ABIM is very common because that's one of the conditions they want us to know and to diagnose. So if you look at the whole world of microcytic anemias, you do have iron deficiency anemia. I use the Tails mnemonic. Reza also has mentioned it a few times. I think it's very helpful trying to consider the other causes of microcytic anemia. So you're correct. Thalassemias, anemia of chronic inflammation, you mentioned iron deficiency, lead, and sideroblastic anemia. So out of the sideroblastic, yeah, a peripheral smear will be helpful. Lead, usually in pediatrics, we do see that. So if you do a peds rotation, you may see that with kids taking in lead paint, maybe in an older apartment or house. I don't know which year constructed when they took lead out of paint. But then definitely anemia of chronic inflammation comes to mind. But in clinical practice, everybody does get anemia panel. You were correct in stating that the hemoglobin is low. I would do an iron panel as well, because if you do diagnose iron deficiency anemia and there's no infection that's happening simultaneously, I would go ahead and treat. And giving intravenous iron can be helpful in raising the blood count a week out rather than giving or waiting for a blood transfusion.
Right. That's a good. Thank you for answering my question, because now thinking of anemia of chronic disease, we could think, as you mentioned, something like inflammation, such as rheumatoid arthritis, lupus, malignancy. And I'm also thinking, could this avascular necrosis be a lytic bone lesion? Because, you know, we have plastic and lytic, and there are some malignancies that can cause these kinds of issues in bone. So yeah, I'm also like trying to keep that in the back of my differential, and definitely like, let's see what's next, what's the next aliquot for more information.
All right. Yeah, there's a lot of labs coming, but first, on the second day of admission, the patient fevered to 101.4, didn't have any new symptoms from like a localization perspective, no cough, no nausea, no vomiting, no diarrhea, and subsequently started on vancomycin and doxy for it, just to essentially cover him for everything. Kind of like you guys had mentioned, the concern for lots of different possible causes. But from a lab workup, while he was still there, his respiratory viral panel was negative, his blood cultures were negative. His UA had 4 red blood cells per high power field and 2 white blood cells per high power field, and then 4 urobilinogen. Urine culture was negative. His lactate was normal, even with the fever. HIV was negative. Hep A, B, and C were all negative. From an iron perspective, his ferritin was 1,050. His percent SAT was 14, and then his reticulocyte percent was 2. His smear that he got showed basically 1% or 1 plasma cell, 2+ anistocytosis, 3+, well, let's see if I can get this right, poikilocytosis, and 3+ target cells. And then sort of following the smear, we also got an LDH, which was elevated at 930. His haptoglobin was less than 10, so undetectable on that lab. And then D-dimer was 3,901. Direct bilia was 1.8, and then his PT and INR were normal. And then just a little bit further workup he had a CT chest kind of following the fever. It showed some small, like calcified old granulomas, otherwise unremarkable besides two very small pericardial lymph nodes. And they got an MRI spine because he had the fever here and then had chronic outpatient back pain, which just showed some diffusely decreased T1 and T2 signal in his marrow, which they couldn't really say was specific for an MPN versus actual medullary hematopoiesis, or just another systemic / metabolic process. And that's what I have for now.
Wow, that's quite a bit to sort of chew on and digest, but I'm just going to go by what really jumps out to me. And many times, I guess, a reason to come on VMR are these abundance of cases with hyperferritinemia. And I always refer to our great friend AMK's schema on elevated causes of hyperferritinemia or cause of hyperferritinemia. So a case that I've always been stuck by because of the vast number of different criteria is HLH. So HLH, like a macrophage, that's after me. But there are other reasons for HLH that you have to wonder about. We have conditions. You can base it on the levels of HLH. So, I mean, levels of ferritinemia. So really high numbers could indicate HLH. But then there are other causes like macrophage activating syndrome. There's cytokine storm syndrome. COVID has been a cause of that, or during the COVID period, we did see a lot of hyperferritinemia. And adult onset Still's disease, if I remember, histoplasmosis can be a cause of this. Interesting with these lymph nodes. And ferritin can be also elevated. Actually, is a very good parameter to indicate iron deficiency anemia, but not to this degree. If it's low, if it's high, it's an acute phase reactant. It would be due to inflammation or anemia of chronic inflammation. So those are a few things that come to mind. What would fit this? I'm not quite sure. And again, HLH is a diagnosis where you are able to configure this condition, but you need to find what's causing it. And there's usually there's a secondary HLH that can happen due to maybe a malignancy or maybe some other inflammatory disorder that you have to wonder about. One more other cause that I forgot about hyperferritinemia is I'm kind of forgetting it again. Hemochromatosis. Yeah, that's the other one that we have to consider. But in this patient, very unlikely due to the lack of signal in the liver. So those are a few things. These calcified granulomas, can this be a condition of something that or pre-existing infection that is calcified over? So you have to start wondering again. Histoplasmosis came to mind. Lymphomas, although calcifications unlikely. Sarcoidosis, also TB could also be a cause of this as well. And then interestingly, I'm gonna let Yasmin think about, or give her some work to do as well. What do you think of this MRI?
This is very interesting. After looking at this, the first thing I thought about, like diffusely decreased marrow signal and issues on bone marrow. I was thinking, well, the first thing I would have said before would have been multiple myeloma or any light chain deposition disease. But remembering what we were taught by Dr. Rad on a nephrology VMR was like CCVC is normal, the RBCs, well, normal, quote unquote, RBCs and red line are normal. So we cannot think about something in that area. Now, another thing after listening, issues in the MRI and granulomas, my mind is going to, could this be a necrotizing or non-necrotizing? And if there is ischiocytic response or not? Because also Dr. Andrew has taught us that on the infiltrative areas, I think I listened to lymphadenopathy. They found lymph nodes over here. I'm pretty sure that I heard that. Correct me if I'm wrong. But histiocytic diseases are also coming into mind after seeing that we can have chronic anemia, we have splenomegaly, we have an insidious process, inflammatory process with weight loss, with night sweats. And although we have a normal RBC, next thing I would like to know is what kind of granuloma are we looking at? Plugging in some of my infectious disease favorite granulomas causes would be obviously tuberculosis, histoplasma, blasto, nocardia, the LS, like Bartonella. And if it's not necrotizing, I will think more of like Coxiella, schizostoma, toxoplasma. So, but in this case, I'm thinking more on the side, could this be a infiltrative process such as histio? But yeah, that's the DDX that I would add. And target cells, of course, we have this differential. Whenever we see target cells, the first thing that I'm thinking, could this be an issue with the hemoglobin? Because that's why there is this, due to the physiopathology, target cells can be due to a trait. Normally we have individuals with sickle cell and we have this vaso-occlusive crisis, but there are also individuals with a trait. So could this be the case with this patient? Could this be a liver disease? In this case, when you see normal LFTs, so slightly elevated, so that's not on the top of my differentials. Could this be due to his anemia? Anemia, but I'm thinking I would like to know more about these granulomas. But yeah.
Yeah, absolutely. I think when there are a couple of multi-system inflammatory conditions, one was mentioned, Vexus, and then you have poems, and then you have so many different types. HLH is one of them as well, where it kind of, when you have multiple different conditions happening at the same time, you have to start wondering about these different syndromes. And this, you actually made a great point. Maybe is there possibly a paraproteinemia, although the kidneys aren't involved. Having this much pathology, you would have at least accumulation of light chains, or immunoglobulins, the plasma cells within the plasma cells within the bone marrow, and then secreting the light chains, heavy chains, and they would plug up pretty much the kidneys. So you would have a signal in the kidneys here. And I think earlier on I had mentioned this reading by the radiologist. I think, Ian, if you can clarify, that they gave a differential of possible extramedullary hematopoiesis versus MPN, so myeloproliferative neoplasia.
Mm-hmm.
Okay,
correct.
Just to make sure. So earlier on I alluded to CML is one of them. So if you look at the vast landscape of MPNs, you have essential thrombocythemia, polycythemia vera, which I think, Yasmin, we did a question yesterday about that, right? Echogenic pruritus. And CML and primary myelofibrosis. And again, out of those, what would kind of fit? MPN was CML. So I just kind of wonder, a study of the peripheral smear would be helpful at this. Let me see. Oh, actually, you do have the data there. Yeah, in the smear. Yeah, so pretty much didn't show anything here. The LDH is very elevated, but LDH I think is not going to get us to, or it's not going to be a catalyst in trying to solve this. LDH could be emanating from the lymph node, it could be from lung, could be from parenchymal disease. So it is helpful when you have hemolytic anemia. LDH will be elevated in this case, but I don't know where it's coming from. Maybe the lymph nodes. Vascular disease can also emanate this, cardiac disease, kidney disease, and then liver disease. So I'm kind of stumped at this point, but let's see, is there the DX next, or is there more information, Ian?
A little bit more, just to sort of hopefully rule some things out for y'all. So from a lab perspective, it's just a lot of lab work. He got a TB quanticle, which was negative. He got a monospot, which was negative. His EBV, CMV, toxo were all negative. Urine histoantigen was negative. Serum beta D glucan was negative. Cocci and crypto were negative. Aspergillus was also negative. Bartonella, Brucella, Leishmania, leptospirosis, and Coxiella testing were all negative. They did a thick and thin smear for malaria, which was also negative. And then they also did Babesia and dengue testing, which was negative. And then on top of that, we also got a SPEP, which didn't show an M spike. And then the flow they did on his blood didn't show any abnormal B cell populations. And then they did a serum NPN panel here, which was negative as well. That is everything I have before the very end.
Oh, interesting. Yeah, this does eliminate a lot of possibilities that we kind of explored along the way. And I think at this point, a lot of the infectious causes we talked about, Yasmin, especially this fever in a returning traveler, we had alluded on it earlier. A lot of these infections could be potentially causative of this, but they're pretty much out of contention at this point. Anything comes to mind?
Yeah, like so far, I think that since I already like scratched out the infections, all this like plasma cell dyscrasias, I think that I'm still thinking, could this still be malignancy? Granulomatous, this process, I would definitely like to know if this has a histiocytic reaction or not, because I'm still not taking off from my differential any of this like Langerhans and not Langerhans cell histiocytosis. And what else? Also, I think that an hemoglobin electrophoresis could be good because again, we have this target cell, we have this bone marrow process. This patient might not have the whole presentation of sickle cell disease, but again, we do know that after reading for the steps and stuff, that there are individuals with traits that can present with some of the symptoms. So yeah, those will be my next step, because thanks to Dr. Ian, we have all of the information, and now I'm really wondering what could be the next step.
So yeah, what's interesting, looking at the retic count, if we just step back and look at the anemia here, it's not devastating, but with the MCV, you would anticipate when you can't make blood, there's a constituent missing, the retic count would be low. But you have to calculate the retic index in this case. So the retic index would be low, but I think hemolytic anemias, retic count would be high, or retic index would be elevated in this case, because the bone marrow is functional, but you've got marked destruction or sequestration in compartments, just like the retroperitoneal space, the thighs, and so on. And you could even have a sequestration in the spleen. Hint, talking about the splenomegaly. But in that case, the retic count will be elevated. Could you have simultaneous bone marrow and peripheral destruction going on? Possibly. LDH would be elevated from that, but the smear didn't show anything. So if you have an autoimmune hemolytic reaction, spherocytes would be evident on the peripheral smear. If you have a MAHA taking place, you would see schistocytes in this case, which we're not seeing here. So kind of interesting, just taking everything together. But I think bone marrow biopsy may be helpful in this case. I'm not sure. Is a signal in the liver as well? The spleen, because whatever is accumulating in the spleen will likely give you the answer. But I'll swing it back to Ian because we're near the end of our hour.
Yeah, there was a long discussion about a bone marrow biopsy that never got done, but the next test, which hopefully will elucidate a fair amount, was a hemoglobin electrophoresis. It showed that he had hemoglobin C levels that were at the 43.6% range, which is elevated, and hemoglobin S was 51.2%. And then his A2 was also elevated at 4.5%, and then 0 hemoglobin A, E, and then 0.7% of hemoglobin F.
It's very interesting. So I'm just putting it together. So the information. So the hemoglobin S was really elevated in this case, as well as the A2.
Oh, so
and C, yeah.
Yeah,
and C.
also trait, right? Because it's the S and the A that is the high one.
Yeah, so he he falls into the SC disease, which is sort of the in between the trait.
yeah.
Yeah.
Wow, and he never had any presentation of SC before?
Not that he's aware of. He had like a splenic injury, but it was unrelated. So we kind of had to sort out, if we really want to call this SC disease, what was the precipitating factor of the attack, like you were saying, especially at the age of 55. So it took a fair amount of back and forth between quite a few teams, but we sort of decided on his travel was to Mexico City, which I think the elevation there is somewhere around 7,000 or so. And so we think that just the elevation of being in Mexico City is what precipitated the sickling event, and caused everything to sort of precipitate from there, and the splenic infarcts and the avascular necrosis that was new that he didn't know about. And so all these sort of new findings that would be consistent with sickle cell, but very odd for someone who was 55 and never had any problems otherwise. But yeah.
Wow, yeah, very interesting that you're right, Mexico City, high elevation, you'd wonder it would be a cause of polycythemia. You tend to have EPO driven. Yeah, this would be an EPO like polycythemia, where EPO would be like negligible or would be low. At a high elevation, there would be a demand on the bone marrow to produce RBCs. And in this case, with the SC disease, you had morphologically abnormal RBCs, though. And he's never played sports or something like that would unmask something like this. So he's never had any issues playing sports or being a weekend warrior or anything like that.
So I don't know if he ever played sports. He was in the military and didn't have any issues as far as he's aware. And then he was doing Taekwondo when he got the injury to his spleen, but prior to that, he didn't know of anything. It was relatively interesting in real time too, because he came in, he's the only patient I've ever had where he said, I have, my spleen hurts. I was like, well, how do you know your spleen hurts? It's because he had a very long, when he had an injury from his spleen previously, it was very bad. So he knew exactly where the pain was from and what it felt like before.
So this is extremely rare. I think, Ian, you have something definitely, I think this could be published and is a great case to present outside of this platform. Reason is then you could help people identify or understand this condition and maybe help them diagnose somebody who may have not been diagnosed previously. So I think it's a brilliant case, and I really have been taught about SC disease, and not always consider it in a younger person, but also in a middle-aged person. And you did a splendid job, such a professional way of presenting a brilliant case. So really appreciate it. Thank you, Ian.
Thank you for having me. It's really all Dr. Azai behind the scenes. I know he's not going to say much, but he deserves all the thanks, not me. And I just really appreciate you guys taking the time to talk about it, because I talked to him about this case because I was sort of unsure, how trying to come up with a differential or thought process of how to work through this in real time. So hearing everyone else's input's been extremely helpful as well, because in real time it was not easy.
Yeah, I can imagine. Yeah, but the workup was fantastic. I gotta applaud you on the brilliant workup that was done in trying to diagnose the patient. And Yasmin, any final words before we do teaching points?
Thank you so much. I think I really did a whole review of every single one of the markers. We went through jaundice, to the unconjugated anemia, conjugated, LDH, alphas. I think that this is really an amazing case, and that I will keep in mind that not because a patient had never had any issues before, we can just discard a diagnosis. So thank you so much. I can see that this was a very, very long, well presented case, and very complex one. Thank you so much.
And Parisa, can we have the teaching points? Thank you.
Yes, thank you so much. It was a really great case. I never know that I need to consider hemoglobin S even in the middle-aged men. Thank you so much. And yes, it was a really great discussion. I learned a lot. And we start with a patient who had the jaundice, and we know that they do not miss diagnosis for jaundice or cholangitis, acute liver failure, and hemolysis. When we need to divide jaundice to indirect and direct. For indirect reasons, we know that we have decreased hepatic uptake, we might have bilirubin production, or we might have impaired conjugation, which is happening in the hereditary reason like Gilbert and Krigler-Najar. There's direct causes, which could be in intrahepatic versus extrahepatic, which are divided in 3 buckets: luminal, stricture, and external causes. We also learn about range of bilirubin in icteric sclera, which is around 2, and for the icteric skin, which would be between 4 to 8, and the middle one is 6. We learn about drug liver injury, which is categorized in the intrahepatic region. Amoxicillin and acetaminophen is notorious for doing so. Amoxicillin could also be in this group. We learned that alkaline phosphatase would be normal in this category versus obstructive disease, which will be happening with elevated alkaline phosphatase. We also learned that rifampin could cause liver injury with decreased hepatic uptake. We talk about palpable aspirin and the causes we need to consider. We need to think about infiltration, hematological infection. We need to think about hematologic malignancy, which could have the cause of infiltration or extramedullary hematopoiesis. We also learned that leukemia could have bone and spleen infiltration. ALL, we need to think about the epidemiology, ALL in younger patients, and CLL and CML in older individual. We also learned that when we have infection with splenomegaly, the 3 main categories should be considered are monoinfection, tick-borne, and granulomatous. We thought that when we have a spleen involvement like organomegaly plus avascular necrosis, one of the first things that's coming to our mind is a storage disease like Gaucher, and also hemolytic anemia, which could be accompanied with low hemoglobin, which was not the case here. We also talk about origin of alkaline phosphatase elevation. First is bone, liver, intestine. Also, it could be placenta and kidney. We talk about tail mnemonic in microcytic anemia. The mnemonic are thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. We also talk about the causes of hyperferritinemia. The most common one, the famous one is HLH, which has a high number, but it could also have other reasons, including macrophage activating syndrome, cytokine storm, COVID could be presented like that, histoplasmosis, adult onset still disease, and also hemochromatosis. We learned that hyperferritinemia, and specifically HLH, usually has the trigger, and we need to address that trigger, which is infection or malignancy. We also talk about granulomatous disease, which could be disease and infections like TB, histoplasmosis, and coccidiomycosis. Great session. Thank you so much, all of you.
Thank you, Parisa. That was a very efficient documentation and all the learning points from this case. So really appreciate it. Thank you very much. And thank you, Ian. Such a brilliant case, and sparing an hour of your day to come on and present this highly educational case. So take care, everybody. Thank you, Yasmin, for co-discussing. Everybody else have a great day. Bye.